And since we can't actually see who wishes to make a comment, what I'll ask is that you please electronically raise your hand if you wish to speak. And if you'll look on your screens, you'll see how to do that. To raise your hand, you click on the Q&A tab on the menu bar of your webinar screen. And then once you're in that Q&A window, click on the hand icon in the upper right corner. And that way your name will be displayed to the meeting presenters. So once I see your name up there, I'll call on your names in the order that they're displayed. And at that time, you'll press *6 and then state your name and your affiliation before asking your question or providing a comment. So you can raise your hand during the presentation, but we're going to wait until the end of the discussion to address those comments. I also wanted to let everybody know that this session is being recorded. So with all that out of the way, I want to introduce today's topic, which is transition of care for sickle cell disease, pediatrics to adult care. And we're so happy to have our presenter, Dr. Ify, with us today. She obtained her medical degree from the University of Nigeria, School of Medical Sciences and Dentistry. And in Nigeria, she provided public health education about sickle cell disease and vaccinations. She has an MPH from Johns Hopkins University and did a pediatric residency at the University of Medicine and Dentistry of New Jersey. She received her Hematology Oncology Fellowship training from Columbia University and has been avidly involved in the sickle cell disease clinical practice for over 20 years. Dr. Ify joined the faculty at Emory University in 2005 and was the medical director for the Children's Healthcare of Atlanta Sickle Cell Program. Dr. Ify is the medical director of the Pediatric Adolescent Teen Scene Transition Program, the medical editor for the Atlanta Sickle Cell Disease Consortium quarterly newsletter, and the director of the Children's Hospital of Atlanta Sickle Cell Awareness Planning Committee. Dr. Ify is board certified in pediatrics and board eligible in pediatric hematology oncology subspecialty. Her research interests include vitamin D deficiency causes and correlates in sickle cell disease, sickle cell chronic pain and bone disease, complementary and alternative therapies in sickle cell disease. So at this time, Dr. Ify, if you'll please unmute your phone by pressing *6, and we can go ahead and begin. Thank you.
Good afternoon, everybody. My name is Dr. Ify. As she said, it's great to have everybody here. I see we have 113 attendees. That's awesome. The title of this talk is Transition of Care for Sickle Cell Disease, Pediatrics to Adults. And I do not claim to be the expert in transition. I think the goal of this webinar is to highlight some of the challenges and some of the practical things that we need to address to be able to successfully get children into adult care as they live longer with sickle cell disease. Next slide. So to make sure we know what we're talking about, this is a normal blood smear, and the next slide shows a slide of a sickle cell patient. And it just reminds us of the pathophysiology of the disease. These people have anemia and abnormally shaped red blood cells that cause multiple organ sequelae. As children with sickle cell disease get older, things change. They have more pain. This slide here shows the pain rates for sickle cell patients, males and females, starting from age 0 all the way down to over the age of 50. And you notice that it peaks in the late adolescent, early young adulthood period, and then tapers down as they become mature adults. Next slide. Now, the rate of pain a sickle cell patient experiences is also related to how long they live. So mortality is proportional to the number of pain episodes per year, with the highest mortality being in the group who have more than 3 severe pain episodes per year. This is from the CSSCD data on 1991. Next slide. Talking about causes of mortality. In pediatrics, I'm a pediatric hematologist, and so I really don't see that much chronic organ damage. Only about 13 to 15% of our patients have some sort of irreversible organ damage in the age group of less than 20. We worry more about infections, strokes, acute chest syndrome, spleen problems, trauma, and other causes of acute illness. And so my job is pretty simple. It's getting them to survive into adulthood by dealing with acute emergencies. What happens when they turn over the age of 20, next slide, is that they end up with chronic organ damage. And then you have to go hunt for problems. Which organ is failing? What can you do to reverse it? Or how can you halt the progression of their disease? Next slide. Next slide. I think we're 2 slides behind. Go back 1 more slide. There is a lag in the transition of slides. Anyway, so the goal of this webinar is to talk about transition. Why is it important? I think all of us know that as you get older, things change in your life, and you have to be able to connect your disease with your day-to-day life into adulthood. There is a very high mortality with sickle cell disease as they get older, and we need to begin early to figure out how to make this work. The American Academy of Pediatrics recommends that every child with a chronic illness is provided a medical home, and that the providers identify core knowledge and skills that may be lacking, and we provide things to fill that gap. We provide them with a portable medical summary and also create a concrete plan for them to move from pediatric care into adult care. For this to work, you have to be able to get the 3 components in place. The patient has to be ready to go to adult care. The mother, the father, the sister, the sibling, the significant other has to be ready. And the providers, both adult and pediatric providers, have to be ready also for this process to work. Next slide. So why is it a big deal? Why do we even talk about transition? Pediatric care is very different from adult care. Pediatric life is very different from adult life. When you're a child, things are great. You know, you have pain here and there, but it's not all the time. Giving you morphine is not that big of a deal. Nobody looks at you funny if you're on morphine in a hospital. The goal is to make you pain-free. You have a lot fewer social problems, financial problems, and emotional problems. And the goal is to keep you alive so you can grow up and leave your mother and your father's house. When you become an adult, it's a very different story. Life is very turbulent, even for a non-sickle cell person in their adult years. You have chronic unremitting pain. Opioids become a bad thing. Being on methadone or morphine all the time has a bad reputation to it. The goal is for you to adjust to pain, adjust to life, as opposed to making you pain-free. And you have progressively more social problems, financial problems, emotional problems, and chronic organ dysfunction. And the goal really should be making you find a way to live in symbiosis with your disease. Next slide. If you've ever walked into an adult hospital, I think there's one, are we 1 slide behind?
Dr. Ify, I think you might be having a delay on your computer.
Yeah, I am.
We're on the slide that says chronic bone and organ damage.
Okay, so I think that's where I am now. So as you get older, things change in your body as well. So a sickle cell patient in childhood has a spine that looks like the second panel, where the bones are nicely aligned. There's no deterioration in the bone. But as they get older, you can see the progression of damage to their bones. And you can believe that this is associated with pain and disability. Next slide. Things happen like chronic leg ulcers, osteomyelitis. I do not see this as much in pediatrics, but I'm sure that the adult providers in the room have seen a lot of leg ulcers and chronic bone infections in their sickle cell adult patients. Next slide. And even though my youngest hip replacement patient is 13, you see this mostly in your older adolescents and young adults as they age with sickle cell disease. They need to have their hips replaced or shoulders replaced because of chronic avascular necrosis damage. Next slide. So what about the different healthcare systems? In pediatrics, I call it uptown. You know, we have a beautiful building, nice, sleek, painted with pictures, and, you know, you have the child life therapist, the dog therapist, the princess fairy, and all those nurturing things in the environment that make it a more comfortable place for a child to be when you're ill. You're usually covered by your parents' insurance or public insurance, and your care is very paternalistic and centralized. You have a lot more providers per patient compared to what it's like when you go downtown to the adult world, where the care is more focused on informing you of your rights and your choices as an adult. It's more patient-centered. It's hard to find a well-funded adult program when you have a chronic illness like sickle cell disease. And insurance is based on your ability to get a job. So if you're not able to work because of your disease, you don't have insurance. Care is fragmented. You have to go to different places to get your care rather than the providers coming to you, which is what we see in pediatric care. Next slide. And so there are a lot of challenges. There is a fear of what would happen when I leave my pediatric doctor. And transitioning occurs at a time when your disease begins to take a turn for the worse. Everybody knows that sickle cell disease progresses with age. It doesn't get better as you get older. We showed the slide early on that shows that pain rates increase between the 18 to 25 age group. And those with sickle cell SC and beta plus style who may not have ever had a pain episode or some sort of sickle cell problem will develop that problem in their young adulthood. The goal is to become independent, both medically, emotionally, and socially, as well as financially. And even though the patients feel ready to transition, none of us are prepared for what really happens when you leave your cocoon of pediatric care, the family, the providers, and the patients. Next slide. So we developed a program here in Atlanta with our goal being to use the normal developmental process of a teenager in modeling a transition program that is practical, supportive, and provides services that the families and the patients require to be able to bridge into adulthood successfully. We want to increase their readiness to transition, their knowledge, and their self-care skills. If you feel confident taking care of yourself, you will be able to be more successful going into adult care. We want them to be more willing to engage in the process of transition, increase their satisfaction, and that the long-term improve outcomes for these patients as they go into adult care. Next slide. So the first step is to figure out who are the players in transition. We decided to start doing what we call the adult and pediatric roundtable discussions where the pediatrician talks to the adult provider, and we discuss issues, barriers, challenges, and come up with a plan that we believe may be productive and successful in this environment. We addressed preconceived ideas about each other. There were and are issues of distrust between the adult providers and the pediatric providers and vice versa, and there is definitely poor communication. Sometimes it's because of HIPAA, but I think there's a lot of a cultural divide between an adult provider and a pediatric provider that causes a lot of this poor communication. And we have very little knowledge about each of the specialties. So I have no idea how to treat a heart attack in an adult person, and I'm sure that the adults don't know how to treat, colic in a child. The bottom line, we need to talk more to each other. Next slide. Who is your team? I believe the most important member of the team is the patient, and I put in brackets the client, their family support. And I think that the third most important person in the transition process is the psychologist, because it really is a developmental and neurobiological process that their body is going to go through, their emotions are going to go through, and their coping is going to have to mature as they go into adult care. We have a program coordinator, social work, child life, program funding source, very, very important. If you have no money, you can't do a transition program, no matter how well-intended you are. The community organizations, our schedulers, admin assistants, and then the medical providers are probably the least important in the team, if I may say so. Next slide. Because you want this to be more of a life skills graduation process rather than I'm treating your sickle cell disease. I'm preparing you for life as an adult. The next step is to provide the right environment. How can you get teenagers engaged in talking about growing up and being independent? You have to figure out what is it that they want, what are they into, what would they like, what would they accept, and you model the environment to fit the teenagers rather than make the teenagers fit into your concept of what transition should be. So we have a teen clinic that we started, and we started about with the age of 13-year-old adolescents. They come in to the clinic and they have a pre-test, which evaluates their basic knowledge of sickle cell disease. What is sickle cell disease? What kind of sickle cell do you have? What is a fever? What are the complications that sickle cell disease can cause? It's a very, very simple 10-question test that they take once they hit the door. And then they have a teen group, and I think that's a very, very important piece of creating the right environment. When teenagers talk to each other, they socialize and they engage with each other. But if they're talking to an adult, they kind of disconnect, and they don't want to hear what you're trying to say. The rest of the clinic, and I'm not going to go into a lot of detail about that, involves the RN interview that talks about compliance and your medications, the doctor talking about your complications and sickle cell health care management, psychology, social work, and then there's a summary at the end where the teenager is given a list of homework assignments that they have to do before their next visit to the teen clinic. And then, of course, we do a survey to figure out what we can do to improve or modify our process. Next slide. And so this shows us the 18 steps to 18, which is what the Atlanta program has devised as a curriculum per se to get a teenager with sickle cell disease to the point where they are ready and able to move into an adult provider's office and stay there. And if you look at number one, it says, I will have a primary doctor and know how to contact that person. Very, very basic, but you'd be surprised at how many 19-year-old boys and girls do not know their doctor's name or the number to the clinic that they're supposed to go to. I will have a hematologist and know the doctor's contact information. I will take my medicines as prescribed. Do they even know what the medicines are and why they take it and how much they're supposed to take? I will carry important phone numbers with me everywhere I go, my pharmacy, the lab, the hospital. I will have a plan to keep my insurance. These are very basic things that an adult should know when you are moving into an adult provider who's going to take care of you. They're going to ask you these questions. Do you have insurance? What kind of insurance do you have? What is your copay? They need to be able to know these things and feel comfortable dialoguing about that with an adult provider. Next slide. While the children are meeting, the parents also meet, and they have a support group, and we call it Letting Go So They Can Grow. And it's amazing what we found out when we started the support group, how the parents have a really, really hard time letting their child with a chronic illness move on into independence. They treat them like little babies because they're always going to be the mommy's little baby, and they kind of stifle their social and emotional development because they're so scared of what could happen when they let them go. So the parents need a focus during the transition process to get them through this difficult period of time. They need to know what's going to happen. Their teens are going to grow up, and they need to be involved in that process. And they have to find another lead in life. You have to let your child go, but find something else to occupy that time that you used to spend taking care of that child 100% of the time. Next slide. The teen group, I think, is extremely important. Teenagers need to understand who they are, what is their role in society, how do they fit in, where are they going, and how are they going to get there. So the best way they can do that is if they dialogue with each other, and we are just facilitators of that dialogue because they learn best from each other. And if you think about the stages of adolescence, they over-differentiate their experiences. Nobody knows it the way I do. Nobody is like me. I'm weird. I'm different. People don't look at me whenever I go outside. They have these feelings and concerns that if you don't address them, you will not get them to where they're independent and confident in who they are as they move out of pediatric care. They question rules and authority. They try to push the envelope a little bit. And so when we talk about transition, it has to remember that certain things are typical for a 17, 18, 19-year-old adolescent. As a matter of fact, in sickle cell disease, they may have a little bit of a delayed adolescent growth spurt in terms of their psychosocial development because of their chronic illness that has to be taken into account as well. And it's very, very important that socialization is part of this whole process of transitioning. Next slide. In that teen group, we have them create a My page. And every child is given a page and said, you know, express yourself. Write something about sickle cell disease that may help somebody else down the line. Pretend that you are going to help a young boy or young girl who has sickle cell disease just like you. What would you tell them that would help them in their journey? And the next couple of slides just kind of show what our patients have, talked about. This is from a little boy who's like 14. He says, am I the only one? I hope not, because I feel so left out of everything. You have so many other things going on. My name is DJ, and I'm 15 years old. I used to ask the same questions, but now I'm not so curious. Next slide. This is a little boy who's 17 years old. And one of the things we found out with this My Page project is that every child is different in how they express themselves, but you can pick up a lot of developmental issues, emotional issues from what they write and how they write it that may be used to tailor their program to suit their needs. So I have a 19-year-old boy who writes like a 13-year-old. He may need special referral to the educating system to figure out how to him with his educational challenges. You have a 13-year-old who writes prose and poetry. Well, he may be one who will be brought to a mentor who can help him write, go into writing or literature as he gets older. Next slide. I like this one. Hi, I'm Tyree, and I have sickle cell, and I played football. When having sickle cell and playing sports, drink a lot of water. I also missed my whole football season, and I'm a senior, and my team had a 6-5 record, and we made history this year for making it to the playoffs since 1970. This is what he's proud about. This is what makes him happy. And trying to figure out a way to help him express himself in this arena is very important. You cannot separate their social life from their medical life. You have to figure out a way to connect the two worlds. Next slide. This is just another page written by a 13-year-old boy. Next slide. So the third step is, well, they've met with the pediatric team. They've gotten to learn about their disease. They're feeling more comfortable talking about sickle cell disease to each other and to the adults in the group. Now they have to go to the adults program and see what it's like out there. this is probably the most traumatic experience for the teenagers. We have a lot of people cry, hang behind in the crowd, not want to go. They're so scared of what they consider the unknown. They take a tour of the adult facility and meet the adult providers, the nurses, the front office staff, the doctors, the social worker, et cetera. And we have a session where we talk about financial planning. This is the hardcore facts about being an adult. How are you going to pay your rent? How are you going to feed yourself? What's your income going to be? Those type of things. And we give them a lot of resources to help them figure this out over the next year. The best part of this session is the girl talk and guy talk. That is usually, we usually serve lunch, a pretty good lunch, where the teenagers talk to adults who have gone through this process before them and who have been there and done that, and who they actually will listen to much more than they listen to the doctor or the nurse. Life after high school, this is a session by vocational rehab where they talk about practical ways of making it outside of high school if you're not going to go the college route. And then we have an open discussion and then talk about the sickle cell top 10 list. Next slide. This is a picture of the girl talk and guy talk. We have a 60-something-year-old woman who is SS. We have a couple of 30-year-olds. We have adult males with sickle cell disease who talk to the patients, and it takes them, I think, an hour and a half, if not more, to get through all their questions. Oh, my God, you can have a baby with sickle cell disease? Oh, I didn't know you could get married. You have a job? Do you go to work every day? Like, what are your challenges? How did you do this? How did you do that? And we let them kind of talk freely and ask free questions so that they can get an idea of what it's like to have sickle cell disease and actually have a functioning, satisfying life. And I think this is a very, very important part of breaking the glass window, per se, of the fear of going into adult care. Next slide. We came up with the top 10 list. We call them the 10 commandments of sickle cell disease, more like life philosophies. And the patients gave us this information. So talking to adults with sickle cell disease, talking to teenagers with sickle cell disease, we asked them, what are the top 10 things you think that you need to know, or you now know that is very important in helping you deal with this disease and adjust to and have a normal life going forward, as normal as possible? The first thing is that you have to accept your disease. If you do not accept your disease, you've already failed the whole transition process, because it means that you don't believe that you need to go through that process. Don't ignore it, respect it, but don't fear it. Learn how to master it and not let it master you. Second one is take good care of yourself. There's only one you. Practice healthy eating habits, drink water, take care of your mind, body, and soul. The third thing is pace yourself. All of our college kids finish high school, they want to go to college, they want to take 25 credits their first semester and graduate in 2 years. Well, that's not going to happen. If you overstress your body, you're not going to make it through the first semester. You got to pace yourself. And the kids who have gone to college and overdone it and fallen backwards are the ones who have given us this advice to pass on to the people who are coming behind them. Remember, you can do everything you set out to do, but always be safe and not sorry. You may have to modify your path to get what you want. It doesn't mean that you should give up your dreams and your desires. Next slide. Learn to control your pain. Sickle cell is a painful disease, okay? And that's what people think about when they think about sickle cell disease. Think about sickle cell pain. You have to figure out a way and have a plan of managing your pain. Do not let your pain manage or control you, because you're not going to have a functioning life if you let that happen. This is where psychology comes into play a lot. I believe that every sickle cell patient should have their own psychologist, like I see, who helps them work through this pain issue, because it's going to be a problem no matter what age you are and no matter how bad your pain is or is not. Develop a focus on something in life that brings you joy and satisfaction. And this is true for everybody, sickle cell or not sickle cell. Set goals and strive to achieve them. Establish independence. Take charge of your disease. You own your sickle cell. Your family and doctors can help you, but it's not their disease, it's yours. Own it. And it talks about engaging actively in your own life and not being a passive recipient of whatever happens to fly by. Next slide. Establish an effective social support within and outside your family. Seek supportive relationships with people who accept you as you are and all that comes with you as a package. It's amazing how many teenagers live through elementary school, middle school, and high school and never tell anybody they have sickle cell disease. Everybody in their family knows they have it, but they hide it from their peers. They're embarrassed, they're ashamed, they're afraid of being singled out or rejected. They have to come to a point where they feel comfortable telling somebody who can support them outside of their family that they have sickle cell disease. Don't waste your pain medication. Don't reach for the pain for the medicine cabinet. So everything that happens to you doesn't have to be treated with a medication. I have back pain. I have a headache. I don't reach for medicine every single time my pain comes up or I have a headache. You got to learn how to cope with discomfort and pain without relying on a pill or a medication every single time. Pain is a pain, but that does not mean that something terrible is happening. People are afraid of what could happen when you're in pain. That's what my teenagers tell me. That's if I'm in this much pain, what's going to happen? Am I going to die? Will I be able to make it past this pain episode? And you have to tell them that pain is not lethal. You're not going to die because you're in pain. You have to be able to face that giant in the room, that elephant that's making you so scared, and deal with it. And find out what is it my fears are. Am I afraid of having a stroke? Am I afraid of having acute chest? Am I afraid of people rejecting me? What is that fear? And then deal with it head on. Next slide. And the last part of our whole program is a graduation. It's a rite of passage where when you're 18 or at the time you complete high school, you graduate from our pediatric sickle cell program into the adult program. And it comes with the pomp and pageantry of the ceremony. You get a diploma, you get a gift, and there's public recognition. And it also is an opportunity to recruit these graduates to help the younger teenagers in the program as they move on to the next phase in their life. There's a lot of peer networking that goes on. And one of the teams that is picked to give the valedictorian speech. And we do this at our Sickle Cell Education Day every year. Around this same period of time, they are also given a copy of their portable medical transfer summary, or at least that's the goal. We review this with the patient from top to toe, so that if they step out of this environment and go somewhere else, they should know what kind of sickle cell they have, what they've had in the past of complications, what works for them for their pain, what doesn't work, and what their ongoing care plan is for pain, acute pain, and for maintaining their health. Next slide. So I want to kind of go over 4 patients that we have had go through this program over the past 3 to 4 years, and just kind of highlight to you the challenges and the successes that we've had. So the first is a female with S beta plus del. She's had chronic pain for 5 years and was on methadone for a long time. She's an A-B student and she wants to be a nurse. So she decided that she wanted to get her driver's license, and you have to come off of methadone because they won't let you drive when you're on methadone. So she determined that she got herself weaned up for her medication. She went to our teen program at the adult hospital when she was 16, and she graduated actually from our program in 11th grade. She didn't wait till she was in, I think, 12th grade before she graduated. She's now in college studying nursing, and she comes by every 6 months to say hi to us, and she's maintaining a close follow-up with her adult hematologist. That's the best case scenario, okay? Motivated young adult, determined, she has pain, she knows how to manage it, she stays positive, she's focused, and she's driven. And she has a lot of family support. The next is XW. It's a female with SC whose past history is significant for recurrent pneumonias and acute chest and recurrent severe pain episodes. She has an IEP in school and is on the vocational track, and she wants to be a barber and a hairstylist. And in high school, she would, sit in the back of the class, and she would cut people's hair and make money off of that. Very, very talented and very, very sweet young girl, but she had some intellectual impairment that required that we modify her 18 steps program to suit her cognitive capacity. So she had to have pictures to show her medications. We had to label her pill box for her with the words and the pictures. She had to describe her pills. It's supposed to tell you the names of the medication, but she knew what they were, and she was able to go through the program. It just took a little bit longer. So she graduated at the age of 20. She's now 23, and she continues to follow up with her adult doctor, and she's continued to do very, very well. She does get sick. She has acute chest and chest pain, but she's, again, very motivated, and she's functioning, and she's doing pretty well. The next slide. I'm going to talk about QM first. He has SS, and he has avascular necrosis, and is on hydroxyurea. Very intelligent young boy. He finished his 18 steps when he turned 18, and he went off to college. But he was always this withdrawn child who just never really engaged with the program or with anybody else. He had no friends in the sickle cell program. He had friends outside of school, but they didn't really know about his sickle cell disease at all. In college, he went on to see an adult hematologist. I would get letters every 6 months about his follow-up appointment. And now 3 years later, I get a letter from the doctor saying that, well, he hasn't been here in a while. He's not taking hydroxyurea. He has poor compliance. And I have no idea what's going to happen to this boy down the line. But I do know that not having a good connection with your adult provider is a high risk for a negative outcome. Going to TJ, he's an SS boy who had a stroke when he was younger, was on transfusions for a very long time, and has iron overload. He also went through the program, and he finished it at the age of 19. Again, we had to modify it a little bit because he had some cognitive impairments. But he ended up going to adult care. He went for his appointments and got settled into the adult program. We found out a couple of months ago that he died of multi-organ failure at an outside hospital, and we were all very shocked. When we went to find out what happened, we found out that he had not been back to the adult hematologist since his second visit after leaving our program. So nobody knows why he died or what happened to him, and we don't know what the reason for his being lost to follow-up was when he did so well with a very compliant past history up until the age of 19 and a half. Next slide. So I showed those case studies to highlight that there are still challenges. No matter how well-intentioned and well-designed the program is, there's going to be loops that need to be closed. There's going to be holes that need to be filled, and you're not going to get 100% success with all of your patients. But they do teach you something, okay? One, we have to start discussions early. Avoid waiting until the last minute because kids are going to grow up, and they're growing up faster these days. We have 13-year-olds who are pregnant. We have 14-year-olds who have STDs. So you can't wait until they're 18 to talk about graduating into adult care. You got to start early. Expect problems. You got to gently usher the patients on, provide hope and a positive outlook, but also be realistic. We can't keep highlighting the beauties of a pediatric world to them and not make them realize that the adult world is a realistic expectation. This is what it is. You and I have to go into an adult system. They will have to go into an adult system. So keep it practical as much as possible. And tailor your program to each patient's social and developmental capacity. So if a child has developmental delay, you have to tailor their program to fit their cognitive ability. Active engagement is extremely important. I think that in retrospect, the boy who was not actively engaged, we could have done a little bit more with getting him seen by psychology and trying to figure out what was it that was going to get him to be more engaged in the process while he was in our program. And then close the loop on transfer of care to adult hematology. This is very difficult because once a child is transferred out of pediatric care to adult care, we don't get any feedback as to what's going on with that patient down the line. There is no system of tracking every pediatric sickle cell patient for the next 10 years to make sure that they're doing well when they're 25 or 30. But maybe there needs to be. Maybe we need to have a system where you leave pediatric care to adult care, but we keep track of what's going on so we can help intervene when things don't go the way we expect them to go. And then track outcomes. Develop a system of tracking to evaluate long-term success of any program. No news is not always good news, as we found out with the case studies I had shown earlier. Who are your adult providers? You have to figure out who are these patients going to. We think they're going to the adult hematologist in town, but maybe they're not. Are they going to the family medicine physician? Are they going to the emergency room? Or are they being seen by the hospitalist in the hospital whenever they get admitted? And when you find out who your adult providers are, you need to engage with them and figure out a way to involve them in that loop of transfer of care. Also, funding for a program. Everything that we mentioned from number 1 to number 7 cannot work unless there's funding. Next slide. So my question is, does sickle cell transition need a survivor link? And you're going to say, what is survivor link? Next slide. It's an information technology network as a tool for helping to ensure childhood cancer survivors in Georgia receive the recommended survivor care and, as a result, optimal health and quality of life. This is a program that's funded by the AHRQ, and basically it's an electronic technology network that links the survivor team, the primary care doctor, and any specialist who's taking care of the patient in this bilateral dialogue where everybody has access to what they need to provide the best care for the patient, but the patient has access to their own plan as well and can drive the way this plan is orchestrated. It includes a survivor health plan, an individualized risk profile, a personal surveillance plan, educational materials to improve awareness, and then guidelines for how to manage a survivor patient and other clinical information needed to provide long-term care. They have CMEs for the providers and for allied health professionals. It's a very interesting program that our survivor program here in Atlanta has piloted for the state of Georgia through the grant they got from the AHRQ. And I'm going to show you some slides coming up next that kind of show you what the website looks like, but they're kind of blurry. So you may want to log on to your computer system to look at to see how it looks like with a clearer screen. But basically, the patient has a password and a PIN number to access this system. And they can pull up their medical records. They cannot modify their medical records. They can pull their record, and they can approve it being sent to X doctor or Y doctor. If they show up anywhere in the state of Georgia, the doctor can pull up their information from this website, and it's all password protected and secure. They figured out all the HIPAA requirements that protect the patient's confidentiality. Next slide. This is how they get started in getting your accounts set up, et cetera. Next slide. I think this is a repeat of the last slide. Next slide. And this is a copy of a health record that talks about what your disease was, what chemotherapy you got, what complications you've had, what your health outcomes were, what documents you have on file. Next slide. And then this talks about your treatment summary and has tabs where you can talk about late effects, risk, and your surveillance plan. Now, could this be devised for sickle cell disease? There are about 270,000 cancer survivors in the state of Georgia, okay? So this makes sense because there's not going to be one adult survivor doctor who will take care of all these patients, or two or three. There are about 100,000 sickle cell patients in this country, maybe a little bit more, maybe a little bit less. But because of how complex the disease is and because of how many people are needed to make sure that these pediatric survivors actually make it into adult care successfully and stay in adult care, I like to propose that maybe sickle cell needs a sickle cell survival link type program that would put the patient in link with the pediatric doctor as well as the adult doctor, the cardiologist, the ophthalmologist, the internist, the family practice, even the hospitalists can pull up the record. And I think if they have access to what works, what doesn't work, what should I be worried about with this patient, I think doctors will feel more comfortable taking care of these patients, even if they're not trained hematologists. And I think overall, the outcomes of these patients will be more positive rather than negative. Next slide. And so to just kind of wrap it up so we can have time for questions, we have our 13th annual Sickle Cell Education Day in September. The final date has not been announced. But I think the whole issue of transition is bigger than one program or one person. It's bigger than one disease. It's bigger than one system, and requires that all of us put our heads together to come up with a program that would work for sickle cell disease that may have to borrow from other chronic illnesses or other disease specialties to make it successful. Thank you very much, and I'm open to questions.
Thank you so much, Dr. Ify. So we're going to now open the lines for questions. I want to remind everyone to unmute your phone if you are called on to speak, and the way you do that is by pressing *6. Again, if you want to ask a question, you need to raise your hand electronically so that your names are called in the order that they're received. And also I wanted to let you know we have this line scheduled for about 18 more minutes, so we have plenty of time for questions, but at the end, at 3 o'clock, I am going to have to end this meeting. So, it looks like we have Danielle Grospich, who has a question. Danielle, if you'd like to press *6, you can ask your question.
Hey, I was just wondering if we would be able to get copies of the PowerPoint.
Oh, so the PowerPoint, it'll probably be a month or two delayed, but all of the PowerPoints for our hemoglobinopathy webinars are archived at the scinfo.org website. So we will be posting this one there as well.
Okay, great. Thank you.
Thank you. It looks like we have a question from Loretta. Loretta, if you'd like to press *6 and you can ask your question.
Took you to get the program to where it is today. You seem to have a lot of different things going on, great things, and I was wondering how long.
How long it took to get the program to where it is?
Yes.
We've been working on this for 5 years.
Wow.
So when we started out this program, we had an emergency situation. We had all these 18, 19, 20-year-olds who had nowhere to go. I didn't know where to go. And they would show up in the ER, and at a certain age, the pediatric ER cannot admit you. So we had to start an intervention quite early. And we gradually, we worked on the older kids and then kind of built backwards down to the 13-year-old program. And now Atlanta has a big sickle cell population. We have 1,700 patients. So we have it on 3 campuses right now to kind of make it easier for patients to get to. But it's incorporated as part of your sickle cell care plan. It's not different from seeing your hematologist. You get to age 13, you got to go to teen clinic. You got to go to teen clinic, you got to go to the teen physician program at the adult center. So it did take a lot of time, a lot of planning, a lot of meetings.
Thank you.
Thank you. It looks like our next question is from Yvonne Carroll. If you'd like to press *6 and ask your question.
This is Yvonne. I wondered, how's your participation in your support groups? Would you say like 10% or 50% of your population that participates in the groups?
So the groups we have as part of the teen program are for the patients who come to the teen clinic. So say we have a clinic of 6 teenagers in the afternoon. Their parents who bring them really have no choice but to be in the parent group. And so the teenagers love it. And even if you're not in the clinic and you happen to be in the hospital during that period of time, we invite those teens to come and join. So the teenagers love it. The parents are a little hesitant if they've never been to a support group before. But I find that once they go, they're like, why haven't I been doing this before? And so as the word goes out, we have more and more buy-in. Now, we had tried to do an independent support group outside of clinic, and that didn't work. Like coming in on a Saturday evening or coming in an evening on a weekday without the kid coming to clinic, that doesn't work. I think it's a logistical issue, not a desire issue. If they're coming with their child to see the doctor, they can sit there and do the support group. But they're not going to come for an extra support group meeting if it's not tied into something else that they have to do.
So how often do you have the support groups?
Every time we have teen clinic. I have teen clinic 3 times, twice a week on each campus, twice a month on each campus. And it's usually different kids. So each child goes through the program twice a year for 7 years until they turn 18, right? 13 to 18, 6 years, whatever. So you do twice a year till you turn 18, but it's going to be different kids each time we have it. So twice a month, all through the year for each campus, and then twice a year for each individual patient.
Okay, thank you.
You're welcome.
It looks like our next question is from Jane Mershan. If you'd like to press *6 and ask your question. Are you available, Jane?
Can you hear me?
Yes, we can.
Yes.
Okay, I just have a question that's a little technical, and it has to do with the kids who need the chronic transfusions.
Mm-hmm.
By the time they're 20 years old, what's an average number of transfusions? In other words, I'm thinking, does everybody get iron overload after the chronic transfusion?
So historically, because the chelation used to be the injection form, the Desferal, I would say yes. So if you had asked this 5 years ago, then everybody who's 19 or 20 has iron overload. What I'm finding now is that we know more about iron overload, and we start earlier to treat it, and we have a more palatable form of treatment. So I do have kids who, they're 16, 17, they've been on blood for maybe 6 years, and their iron levels are not that high. But the kids who had, the kids in my presentation who are now 23, 24, they were all of them on transfusion were iron overloaded because nobody did the Desferal like they were supposed to. It was a pain in the neck. But now with the pill form, I think we have a better chance of not having all of them being iron overloaded.
Okay, thank you.
Does that answer your question?
Yes, it does.
Yeah.
Thank you.
Thank you. Our next one is from Pamela King. So if you'd like to press *6, Pamela, and ask your question.
Thank you. My question is, did you have a community-based organization as a partner or collaborator, and if so, what role did they play?
So absolutely, yes. We have the Sickle Cell Foundation of Georgia, and we used to have a time when they would come up to the clinics once a month, but due to funding constraints, they don't do that anymore. So the biggest role they play is when we go to the adult facility and do the program there. members of the foundation are, when you saw the Girl Talk and Guy Talk, many of them have sickle cell disease, and they are our adult peers, our adult mentors who come and talk to the kids. Some of them come to help the parents in the parent group that happens on that day, and at the education day, when we have the graduation, they're definitely featured on that day as well. Does that answer your question?
Okay, it sounds like it. Thank you very much. Next, we have someone from Children's Hospital Los Angeles. If you'd like to press *6 and ask your question.
Hi, can you hear me?
Yes, we can.
Okay, hi, I'm calling from CHLA. My question is, how do you specifically reach out to the adult providers that will assume care of the adult patients? And then do you specifically look at hematologists, or is your program open to look at other adult providers such as internal medicine or family practice?
So you start with that's a great question. You start with the landscape of the city where you live in. So in Atlanta, we have the Grady program, which is the adult facility, so he was my #1 contact, and I have him on speed dial, Dr. Ekman. But of course, not one person can see 1,600 kids as they get older. So what we do, we have adult hematology oncology practitioners across the city of Atlanta who we talk to and ask them, are you willing to see sickle cell patients? Do you have room in your practice? And what's your comfort level? Some of them say, send us the ones who are not that complicated. Some of them say, you know what, I can do transfusions, I can do exchanges, I can do X, Y, Z. And we have them on, we have a list that we compile, and we ask the families to pick somebody who is closest to them in terms of where they live and their logistics, and then go for the visit and kind of get to know the person, then come back and report back. Some of the adults at the foundation have referred their doctors to us and said, hey, I see this doctor and I think he's great. You can put him on the list of people we can use. In terms of family practice and internal medicine providers, we don't have that many, but we do have some. And then what we do, we ask this patient to have both an internal medicine provider and a sickle cell provider. And you may see one or the other depending on how your disease is acting up. So I have an internal medicine doctor who sees a lot of my SC and S beta plus patients. When they come back from college, they get all their stuff there, and then they just get the guidelines from us, and we kind of dialogue about what needs to happen and what they need to look out for. So it's a mixture. In Atlanta, I think it's more heavily towards hematologists, but there are some internal medicine and family practice providers. But I think now we're beginning to try to engage them even more, because I think the landscape going forward is going to require more primary care for sickle cell patients than specialty care, because the numbers of hematologists are just too few on the adult side.
And will they only take a specific number of patients? Like they'll only, do they have like a limit of how many they would see? And then do you have any long-term partnership with them as far as maintaining a connection with the patient once they leave your
practice,
your facility?
Both are very good questions. So some of the practices can only take a certain number of sickle cell patients because they're usually hematology oncology practices and they're not specifically sickle cell practices, and we have so many patients here. The adult hematology program at Grady can see as many of our patients as can come there. But if you live like 2 hours away, you're not going to drive all the way into Atlanta just to see your sickle cell doctor unless it's a really big emergency. And there are a handful of the doctors that I have an ongoing partnership with where I get letters every 6 months from them about any of my patients I've sent to them. And like the boy in the presentation, he's been gone for about 3-4 years, and I still get every 6 months a letter from that doctor. We meet at meetings sometimes and in different community events, and so we kind of catch up that way. But I have all of their numbers on my cell phone, and I can call them in a minute and say, hey, what about this kid? What's going on here? Or they can call me and say, I have this kid, but I can't get through to this child about what they need to do. Can you talk to the patient? It gets a little tricky when they get past the age of 21, and we haven't figured out how to really keep a good tracking system on the patient. So if the patient is going to the doctor, all is great. I refer them to you. You can contact me. HIPAA is fine. But if they don't show up at the hematologist and they're no longer my patients anymore, I don't know where they live. How do I keep tab on what's happening with them, and how do I get them plugged back in if they don't seek us out?
So are you limited in your clinic with the age that you can continue to see patients?
Yes. So in our clinic, we can see up to the age of 18. In rare circumstances, we can see 21. The hospital will not admit you after you're 21 years old.
Okay.
And like I said before, so we have 3 clinics. Each of them has about 600 patients, and we don't have enough staff to see more than what we're seeing right now. I think that's kind of like the rate limiting step.
Okay. Okay. Thank you.
All right.
Wonderful. Thank you. And it looks like we have one more question, and that's from Irene. So Irene, if you would like to press *6 and ask your question. Is Irene on the line?
Yes.
Yes, great.
My question is, I noticed on your materials that you have AFLAC, and I was wondering if they underfunded or they funded part of your program, and if you have other grants that are funding the program.
So the Pediatric Hematology Oncology program at Emory, or Children's Health of Atlanta, is funded by the AFLAC organization. So basically, yes. But it's a Pediatric Hematology Oncology and Transplant program. So we get a lot of our support from the AFLAC group, and we're grateful for that support. We don't have a lot of outside funding for the Sickle Cell Transition program. The hospital is working on an ongoing project to kind of tie together transition for all the different disease states, so not just sickle cell, but congenital heart disease, cystic fibrosis, renal transplant, heart transplant. So we're working on something on that regard, but as of this point in time, we only have what each program's funders have provided. And I think, for us to have done what we've done, it's a testament to how much support we've gotten from our institution, our sponsors. But I think for us to move to the next level and get a more systematic, especially to tie the loop of long-term follow-up, we're going to need significant grant funding for that.
Wonderful. Thank you. So that looks like all of the questions that people raised their hand for on the computer. But I do want to see, since we have about 5 minutes left, if anyone who didn't have access to raising their hand on the computer. Oh, sorry. We have one more, Holly Avey. Holly? You want to press *6, Holly, and ask your question?
Yes. Can you hear me?
Yeah, we sure can.
Great. I just wanted to ask a question about one of the first slides with the increase in pain that was shown according to age range. I wanted to know if some of the data that we've had here in Georgia shows that there's an increase in healthcare utilization during those same times. I was wondering if the spike in both is related in any way, if as people transition from pediatric care to adult care and do not have a smooth transition and don't get as much care, if that could result in increase in pain episodes, or if it's a completely separate and parallel process.
I think that's an awesome question. I think it's a combination of 2 processes, maybe more. I think as you get older, your disease progresses. Okay, you develop chronic bone damage. You have avascular necrosis, and so that in and of itself will result in increasing pain, whether you're in good care or not in good care. We do not know enough to prevent bone damage in sickle cell disease. We can prevent pain with hydroxyurea, but we haven't figured out how to prevent your bones from deteriorating over time. So that's one reason why they have increased pain as they get older. But I definitely think that when they do not have a smooth transition from pediatrics to adult care, they end up getting all of their care in an urgent care center and an emergency room and being treated by hospitalists at outlying hospitals, and there's no comprehensive plan to figure out how to reduce your pain. And so, yes, the same way we have the higher mortality in that age group, that also involves increasing pain, increasing acute chest. There's a lot of psychosocial challenges that come along with that period of time that can increase your pain. So it is a combination of those 2 processes. You're absolutely right.
Wonderful. And it looks like, Dr. Ify, we've had a question if you would be willing to share your contact information with the group.
Oh, okay. Absolutely. So would you can put that on the website, or should my email address is ify.osunkwo@choa.org, but you may have to spell it out because my name is a little bit difficult to pronounce. So it's ify.os as in Sam, UN as in Nancy, KWO choa.org.
Wonderful. Thank you. And if anybody didn't get a chance to write that down, if you want to email Shay Pope, and that's the person you receive the emails with the information about the webinars from, you can email Shay and she can provide that email address to you as well. And then I think we have time for one more quick question, and that again is from Jane Mershon. Jane, if you want to ask your question. Push *6.
Technical again.
There you go.
It had to do with what I asked before about the average number of transfusions, and also to link on to that, from a laboratory perspective, are you quantitating the %S and the %A, or do you exclusively rely on just the hemoglobin hematocrit to determine how much more blood they need when they come in for a crisis?
Let me try to see if I can answer your question. So in pediatrics, one of the philosophies that we've kind of stuck with here in Atlanta is we try not to transfuse you just because of pain, okay? Because of the issues with antibody formation, iron overload, et cetera, with transfusions, we have a program where if you have had a stroke or acute chest or some other life-threatening event, we transfuse you. And in those patients, we use both the hematocrit, with the hemoglobin, and the %S, and we have a target. So if you have acute chest, the target is going to be like 50% S. If you've had a stroke, the target will be less than 30% S. If it's because of your spleen, it's going to be less than 50% S. So for each indication, we have guidelines that kind of guide how much blood we give based on your hematocrit, or your hemoglobin, and your %S. And also, of course, your body weight, because it's we're a pediatric program. And we kind of play around with the interval with which you come to get your blood versus the amount of blood you get, and where we want to keep your pre-transfusion hemoglobin level at. So we use all of those things, and and maybe I can talk to you offline about that because it's not really as pertinent to this discussion. But we typically do not transfuse for pain, which is something that happens a lot outside of specialty centers. If you come into the ER or a hospital that doesn't know you and your hemoglobin is 6, and you're looking very sick, they transfuse you. I think the issue becomes, as they get older, they develop antibodies where giving blood becomes more of a risk than a benefit. And that's some of the reasons why some of our patients have passed on due to delayed hemolytic transfusion reactions. It's a little bit complex. But we can talk about that offline if you need more details.
Yeah, I would love to talk to you offline. Thank you so much, though.
You are welcome.
Dr. Ify, thank you so much. Unfortunately, our time is up for today. But I'm sure that if you have further questions, you can either address them to Dr. Ify, the email address she gave you directly, or if you would like, you can email Shay, and her email address is spope@cdc.gov, and we can pass those questions on to Dr. Ify. Again, this presentation probably in the next month or two will be archived and available at scinfo.org. But in the meantime, if you would like to go there, Dr. Ify also gave a presentation for the webinar series last year, and that was on vitamin D and sickle cell disease patients, and that is currently available. So if you'd like to go and look at that presentation, along with any others that are on that website. So thank you so much. We had an incredible number of people listening in today. There were some great questions at the end. So I wanted to remind you that our next webinar is going to take place on Thursday, February 23rd. That is a medical home model for sickle cell disease, and the presenter is Dr. Michael DeBon of Vanderbilt University. So if you have any questions, feel free to contact us here at CDC. Thank you so much. I hope everybody has a great afternoon. Bye-bye.
Bye-bye.